None of the producers have any financial interest in the products or procedures shown. Posterior chamber phakic IOLs have become popular for the treatment of myopia. However, just as with any other procedure, complications may occur, and the surgeon needs to be familiar with its prevention, diagnosis and management. An inverted ICL may be diagnosed on ASOCT as well as clinically. An inverted ICL, if left alone, can lead to the development of cataract, necessitating explantation. So what does one do if faced with an inverted or flipped ICL? The ICL edge markings may be seen flipped. In experienced hands, it is possible to re-invert a flipped ICL. The ICL is rotated to make it lie horizontal and the edge lifted up with viscoelastic injected under it. It is then folded on itself so as to bring the convex side superiorly. A flipped ICL may also give rise to post-operative inflammation and must be corrected. The technique of viscocannula-assisted re-inversion of ICL should be performed very carefully while making sure at all times to avoid contact with the endothelium or the lens capsule. An inverted ICL may also be tackled by explanting the IOL and re-implanting it. This can be done by simply pulling the ICL out, slightly enlarging the incision and pulling the ICL out, or by putting a cut in the ICL and rotating it out of the incision. An inflamed iris and a small pupil may require iris hooks to be used. In case difficulty is experienced in viscocannula-assisted re-inversion, the ICL may be explanted by pulling it out. The ICL is then re-implanted carefully. The incision need not necessarily be enlarged for explantation of an ICL. However, care should be taken not to damage any intraocular structures during explantation. If required, the incision may be enlarged slightly. Since the material is extremely flexible, it is easy to simply pull the ICL out of the incision as seen in this case, where it comes out easily despite not being pulled out along the long axis. Explantation of the ICL may become necessary in the setting of a cataract. A white intumescent cataract may be associated with problems in completing the rhexis successfully. However, the patients generally being young do not have a significantly dense nucleus. IOL power calculation should be performed carefully. Large iridectomy should be avoided as they can cause diplopia, especially if not covered by the lid. These may be sutured and made smaller if required. Post-operative inflammation may lead to glaucoma, which might require a trabeculectomy, and the cataract can usually be removed easily. Neglected cases can present with severe post-operative inflammation, glaucoma, and cataract formation. It is therefore generally advisable to explant the ICL before such severe post-operative complications occur. Patients may also present sometimes with a delayed onset cataract. Viscoelastic is injected between the ICL and the cataractus lens, and the ICL is prolapsed into the anterior chamber. The ICL is partially cut and explanted by rotating it out. Trypan blue may be instilled to stain the capsule and the cataractus lens aspirated. Improper loading of the ICL into the cartridge can lead to difficult implantation. An improperly loaded ICL may get stuck in the cartridge and not get injected into the AC. Forceful pushing may lead to tearing of the ICL and inability to implant it. Having a backup lens may be a good option for beginning surgeons. It is important to avoid air bubbles in the cartridge which interfere with visualization. The marks to identify side are the holes on the ICL haptics corners. This should be visible on the leading right and on the trailing left haptic. The central linear etching denotes the axis of cylinder. The lens is loaded convex side up. It is important not to twist the ICL while pulling it into the cartridge. If the axis etchings remain inline and aligned with the cartridge lock, simple injection avoids a flipped or inverted ICL. In case axis etchings are inline but not aligned with the cartridge lock, the injector is twisted so as to have the axis etchings face upwards. If the ICL is twisted within the cartridge, it is important to ensure that the leading axis etching faces upwards before injecting. Once the leading haptic has unfolded in the AC, the injector is twisted to now face the trailing axis etching upwards before injecting further. Keeping a rod on top of the ICL while unfolding prevents unintentional twisting of the ICL. Slow injection and waiting to have the leading haptics unfolded before further injecting is crucial. Once completely in the anterior chamber, the haptics are gently flexed under the iris. Viscoelastic is removed. Intraocular myocall is injected to constrict the pupil. A peripheral iridectomy is not required with the newer model V5 or Centraflow model. Once the toric ICL is injected, it is rotated to have the axis etchings aligned with the axis marked on the cornea. It is helpful to have the ICL placement sheet held upside down to align it correctly to the surgeon's perspective of the eye being operated on. Postoperative posterior segment complications can be avoided by careful patient selection. A rotated ICL, if significant enough postoperatively to affect vision, needs to be rotated again into the correct axis. To conclude, Visian ICL is a good option not only for the treatment of moderate to high myopia, but also in other conditions such as stabilized keratoconus. It is important for the operating surgeon to be aware of different complications and various modalities of management to have happy outcomes.